Great, welcome back to the Healthcare Committee. So we are gonna focus our time for the next 40 minutes or so on the budget document we have. So the first page is the stuff that's come in, not from the governor's recommend. So let's skip that for now and go to the dollar section. And Viva. So I'm just gonna go down the line and say, I don't think these are things we need to consider or prioritize. Obviously, I'm open to what others think. No one might have some comments too. So if just gonna start with the B306, reduction in office rents and operational reductions. That's fine.
We're
That's fine. We're not gonna comment on that.
not gonna look at that.
No. B307, which is the caseload and utilization. So this is what we have every year. We have caseload and utilization. And if things need to be adjusted, they come back in BAA. So we're not gonna look at that one or the buy-in caseload. Then we have the dental rate increase, which obviously we'll discuss. Drug coverage, drug coverage changes with pharmacy benefit, we'll discuss.
And just so you know,
Yes.
in that B307, I will also be sticking in the dental for CRT.
Okay,
That we just heard about. It's been right underneath there.
great.
Thank you.
Thank
And that
you.
number will be, just so you have it, it's 198,821. And that would fall under the Medicaid GCF line.
Okay. So is it net neutral?
According to them, it is, based on their budget construct.
Okay. Okay. So then B309 caseload and utilization and clawback. Or not things we'll talk about.
But not things we'll talk about, yeah, okay.
Eliminate Vermont cost sharing and drug coverage benefits, we will. Again, we're back into the caseload and utilization, buy-in caseload and CHIP FMAP change, which is really a zero. So those we won't talk about.
What about the drug coverage changes?
Yes. And Nolan, can you help me understand or help us understand? So there's drug coverage changes with pharmacy benefit in B307, B309, and B310.
What they're saying is that it's located in 3 different sections of the budget because of how they're drawing match. So some of it is global commitment, which means it's gonna get matched. Some of it is state-only dollars, which means it's not matched, we have to use state dollars. And then non-waiver, it just means it's outside of our global commitment waiver, which means doing something slightly different than global commitment rules.
Okay, but when we make a decision, we would be making a decision on the combined 3 lines.
I would recommend that.
Okay. All right, so now we're on B314, and this is overtime for River Valley. If you remember, River Valley is the new Middlesex and Essex. It will be opening. I would suggest we're not going to discuss that one. And then the increase in vacancy savings, we won't discuss. And then the IMD investment phase down and the convert elder care outreach to investment, we won't discuss. That's just moving money. Then we have the mobile crisis, which we'll discuss. Secure residential operating increases, again, for River Valley, I suggest we don't discuss that. And we will discuss the 988 suicide prevention line. That takes us through that section.
I have a bunch more.
Yeah, looking at the whole bunch.
Oh, sorry, maybe I'm on a different page. So now, yep, so now we're going to CMC Service Point License for Housing. I'm not sure what that is, so we'll discuss it because I gotta figure that out.
I have.
Okay,
Yeah.
so Daisy will talk about it. B314 and so the convert suicide prevention grant to investment, both of those we won't discuss. It's just moving of money. And then peer support credentialing and therapeutic alternatives we will discuss. Now we are in the one-time money,
I'm sorry, you said convert pathways to support line, not discuss.
not discuss.
Oh, I see, 0, sorry.
So then we have one-time money. expediting competency and sanity evaluations and Green Mountain Care Board. We will discuss those a little bit. We haven't taken testimony, but I know Daisy's been doing some homework. The healthcare workforce position, this is what we put in legislation last year, so we're not discussing that.
Where are you? I'm sorry.
The fifth line under one time, AHS.
Got it.
And all the ones above it, we won't discuss.
Oh,
We will.
We will.
All the ones above it, you will. All right.
And then on the one-time appropriation to address emergent circumstances impacting healthcare providers, we'll discuss that. There's been a request for asking for a report back. And then the next one is the one-time appropriation for the matching funds. So we're not going to discuss this, but Nolan, can you answer Leslie's question as to why this money is here under one time?
So it's really an accounting function where they're trying to recognize that all the people that are in the system right now, because of the lack of redetermination, it's an estimate of how many people are going to come off. And it's a sense that since we don't want them in the base, when we try to do our trend lines, we're kind of pulling them out a little bit because we recognize that they won't be in next year's budget. So the idea is to pull those folks out and look at them as one time, because this year they technically are. They won't be base next year. Whereas the people that with our normal trends, the way I look at it is here's our normal trend, and then here's what's happened in the pandemic.
Right.
And there's all these people that are in the system. So it's trying to pull them out, look at them as one time for this year, because they won't be part of the base next year.
Because of the redeterminations and people will be coming off Medicaid.
I was actually wondering that, so you went back to 19 or they did to see what their sort of usual and customary numbers were?
We tracked it.
Yeah, and are those numbers still reasonable so that when you rebudget, you're going to go back to 19 numbers just to start thinking of 20?
There's some method that's being used to sort of estimate how many people come off, and it's all reasonable. We've looked at it, and we never know. It's like when you do a new program, we make estimates,
Yeah.
and then the budget adjustment will be like, oops. But it's all based on the best information we have and the best modeling we have, and it's all consensus. So I'm comfortable with it.
Yeah, so I'm just trying to understand it. So what you're saying is that you're taking the Medicaid population currently.
We're estimating how many are going to come off and how many are going to stay on.
Right.
Yeah.
And moving it from.
And that the $10 million does what?
So we're not gonna discuss it.
No.
It's just moving it from base to one time so that it's not in the base.
Because we won't need the money next year in the base.
Because it's for the amount of people you're paying for this year that will therefore be off next year.
That is the estimate, yes.
Estimate, yes.
Thank you.
It's an accounting exercise.
Yeah.
So that line and the 13 million that matches it, we will not be discussing. So now we're on the RNG line, which is human services, so we won't be discussing that. And the next several lines are the blueprint, which we will be discussing. And then we go to the language, which I am not suggesting we discuss any of it except for potentially the limited services proposal. Actually, let me go back up. So the third line down under the language, it says DMH multiple permanent positions. That's just the language that goes with the mobile crisis dollars.
Which one's that, Lori?
So it's the third line down under language.
The top of the second page.
Yeah, our pages are different than yours.
Okay, but it's the third
So
line
the third
down
line
after
down.
language. After it says language on the pink.
U100A1H.
Yep.
Yes,
So we're gonna discuss it.
yeah, so that goes with the mobile crisis,
Okay,
right? And then the next one is the 35 limited services positions.
and we're gonna discuss both those.
Yes.
Okay,
In line with the other stuff. And then I would think the only other thing we'd really discuss is a second from the bottom of the list, E309, which is the Vermont cost sharing reductions elimination, because that's the language that goes with that 500,000 that we're contemplating not accepting as a budget recommend. So does that hopefully help narrow down what we're gonna be talking about tomorrow?
Quick question, I'm sorry. What's this color mean? Does it have a meaning? Does,
It's with the one that we won't be doing, House Human Services will be used.
that's why, I'm sorry.
Yep,
It was in the memo from appropriations, but it should have been.
right, yeah.
Yours.
So tomorrow we'll have a much broader discussion, but I think I'm curious if anyone's willing to share now what they're thinking about some of the proposals that have been before us, either by proposal or holistically as we look at the budget. Any general thoughts so I can get a feel for where people are, figure out how we move forward tomorrow. And if you're not ready, that's fine.
Well, I'm ready to say on the 500,000, I don't agree with that.
You don't agree with us taking that out?
No. I mean, that's only my.
Yeah, no, I know.
Personally, and it's, again, it's coming from somebody still struggling to learn all this.
You're doing very well.
Well,
You're asking some great questions.
Great question, yeah.
I would rather see us put as much money as we can in the Medicaid reimbursement than to do some of the other things we have here as requests, personally. Because it seems to me that we've got to shore up our physicians, our PAs, our private medical providers. They're gonna keep the doors open. I feel I would like to see us put as much as we can to that personally. So that's what I'm looking at.
And you made a comment earlier, Art, that you don't understand why we're not 100% of Medicare. That is strictly $1.
Oh, I know.
Yeah.
Oh, I know. I know we can't.
Okay. No, I mean, I'm not saying we can't do it, but that's why it's just.
Oh, I know.
It is within the administration's and ours jurisdiction to increase our state general fund to do that.
I'd like to see us do it as much as we can here, and maybe some initiatives we want to do, to just me talking, that are good to do, like for health, it's a lot of money, maybe we put that into Medicaid reimbursement instead. That's my thought.
Yep.
Along the way here right now.
Mario, I'll get to you in a second. So and that brings me to a good reminder for when we're talking tomorrow. So we have to keep in mind what is as a base versus one-time funding. So in that example, because I was actually thinking the same thing you were last night. We have, $10 million, $20 million over 2 years going to Blueprint, which is very, very, very important. But it's a 2-year pilot. Would it be better to put that $20 million into Medicaid rates? But that's one-time money. So that's not going to help us increase Medicaid rates because the Medicaid rates should go in the base funding
Okay.
so that they get it every year, kind of like the dental. So they're increasing the dental rates and that's going to be in
Yeah.
year after year after year.
The thing is, I bet dollars to donuts, that pilot becomes permanent.
Yeah. Well, and if it is, that's good too, because it is also going to providers
Yeah.
to help keep the doors open and help people.
They
Yeah.
have to come back and propose it to you.
Exactly.
How many employees was that?
So it wasn't state employees, it was employees into providers.
Right.
I think he said potentially 50.
Okay.
With some that are already in positions and maybe can work more hours because maybe they could go from part-time to full-time because they might have more money. Maureen?
Seconding Art's comment about supporting primary care and making sure that we, however we can, are supporting independent practitioners.
Thank you. Leslie?
We may have already had this number, but I don't, it's gone by me. What percent of Medicaid are we at now compared to Medicare?
For what? Because everyone's,
So everything's different. So that's the chaos is that, so how does the 3.8% that seems to be being asked, at least from primary care?
so that's so, and we'll actually, let's talk about something. So if you look at the first two lines of the very first page, so the VMS and Health First Primary and Specialty Care. So basically, when we say we're going to increase Medicaid rates for primary care, that will impact a lot of places. It will not impact FQHCs or DAs, but it helps the independents, it helps the specialty practices, it helps primary care. So the first line there, I have it highlighted, the font in red, so hopefully you see that. Primary care, that would be a total going to our primary care providers of $677,000.
And that's the Medicaid rate?
That would be,
This would be if we increase, so we increase by 3.8%, which is the Medicare economic inflator.
Okay.
So it's not really saying we're gonna go to 100%, we're gonna, but it's adding 3.8% up.
Yeah.
And then the next line is for the specialty care practices. That's 3.8 million total dollars. So I have to admit, when I saw the 677 for primary care, I thought, wow, that's pretty low
Yeah.
for primary care. So Alyssa's been doing some work, and we'll have a couple of proposals to put out tomorrow.
great. Because I was a little surprised too. Like,
Yeah, so that's where those two numbers are.
Another one that I'm interested in looking at is the Looper,
Yes,
going to 100% rather than 90
yes.
now.
Anyone else want to comment before we? You don't have to. Bobby?
I just had a question about the $10 million to address emergent and exigent circumstances impacting healthcare providers.
Yeah.
Like a rainy day fund? I mean, what is that?
No, you weren't here, I don't think, maybe. So the Secretary of AHS was in here on Friday. You might have already been.
That's when I left. That
Yes.
must be why, okay.
Yes. So you can listen to her testimony, but it's a continuation. It's more money into a fund that we started during COVID, and it's to help practices and healthcare facilities, people who are struggling really because of workforce and COVID. And so she provided testimony on that. And then Leslie and others have asked that maybe we put in the budget intent language that not intent language, but a request that they report back to us on how that money's being used. And again, that's one-time money.
I need to dye my hair.
It's like I'm talking to my three sisters. I never get their names.
Well, you
right,
called
so.
Alyssa earlier and I was like, gosh, I gotta come up with something quick. So I just wanna put out there, obviously the primary care, but EMS is a priority for me. Our emergency services, I think, are in crisis across this entire state. And to me, that is a priority.
Where is that on here?
That's on the first page,
EMS.
Oh, gotcha, all
Under
right.
the governor's recommendation.
Okay, gotcha.
not under the governor's.
I mean, not
Yeah.
under the governor's
Yeah.
recommendation.
Okay. Excuse me?
I think what I'm gonna do tonight to prepare for that discussion is review our guiding principles that Topper and Leslie and others anchored our whole committee in. Okay, we all
We
did.
all agreed to it.
Because I think really a budget is a values statement and a values recommendation by this committee to how we're gonna advance the wellness of our entire state. And this is a really difficult and impactful recommendation that we're gonna make. And I think anchoring myself in what our intention really is behind these recommendations is gonna be really helpful for preparing for that conversation tomorrow.
think we should all do that. And our job is not to say, well, we're gonna recommend X, so we need to find the money to offset the increase. That's not our job, that's appropriations job. So we can put forth everything on here.
Yeah.
You know, we can. We have to prioritize. That is the key. Because if we just say, here, we want everything, they're gonna say, oh, well, so does everyone else. So what do you really want? So as we have this discussion, we don't need to find the money, but we do need to prioritize. And so I think that's where, you know, Daisy's comment about the guiding principles will be really important.
I think we should do some research on the sport of curling. Woody's our rep, the guy, and you know how much he loves curling.
Yes.
We threw some things out, he might.
He might help us. Yes, that's true. I have a feeling he's gonna be all over the Northeast Therapeutic.
Yeah. Oh, yeah.
Yeah. Leslie?
I think I understand this, but just so everyone does, the subtleties of our conversation gets communicated to appropriations by you and Alyssa and Daisy, right? That's how that works.
Yeah, so we'll, you know, fill this out for them. We'll put any language we want. I would suggest that we will come up with an intent piece around, you know, why we got to where we are. As an overall, and then, yes, there will be people who will present this to appropriations.
So there'll be a cover letter to this spreadsheet
I don't know if it'll be a cover letter or it will be in the spreadsheet.
in the notes.
I'll figure that out with Ameren,
Yeah.
see what's best.
Thank you.
Could you just repeat what you just said about who's gonna write something?
Well, we, as a group,
Yeah,
will decide what language needs to be included in here.
okay, but Lori, you said something and then you said, yeah.
I said it will be in the notes. I mean, that it seemed like what I'm understanding is that this spreadsheet is what's going to appropriations. Lori, Alyssa, Daisy will kind of present this information. Our intentions will be on the spreadsheet and maybe in a cover letter as Lori decides what makes sense.
Well, we as a committee will decide what we're gonna say.
Yeah, but then the communication.
Format will be, yes.
Okay. I got some pretty strong opinions about this.
Okay.
And if I'm not gonna be part of the team that's gonna be presenting it, then I wanna be in the room.
That's fine. And anyone can talk to anyone in appropriations about anything they feel strongly about. Normally what happens is whoever the budget liaison is or the chair will present.
Oh, okay.
The findings
All right,
of the
I got
committee,
it. Okay,
that's-
time out. I take it back. That's right. Budget liaison.
Right,
Okay. I'm cool.
okay.
That's fine,
I'm
learn
really
about
curious to know what
curling.
you're gonna
You know,
say.
play hockey, learn about curling.
Wait, I wanna watch this too.
Yeah, I'm curious here.
Just wanna make sure I can get the people.
The right people.
And everyone knows where the appropriations committee is, so feel free to talk to them in the hall. So I just wanted to also, so there's a couple on here that I have in a note that says workforce bill ? Under the third column. I have reached out to Commerce, who's putting together a workforce bill with this 3 things we've heard about, which is the education for all EMS providers, Vermont Care Partners request for tuition assistance or loan repayment, and putting more money into the nurse forgivable loan program. I've just reached out to them and said, we've heard testimony. Let's talk about potentially putting something in their bill, would not be necessarily in our budget request. I think, other than the changes Nolan's gonna send, and he'll send it out to me and then we'll get it out to everyone before tomorrow morning. And Claire, I'm gonna ask that you print again for everyone, that would be great. Okay, I know it was a long afternoon. Thank you. Tomorrow morning will be a great conversation, but it won't be easy. Or maybe it will. I don't know. We might all agree on everything.
So we sort of have to be done with this by noon, right? I mean, if
My hope is that we are, at least have, our directions to where we're going. If we have to come back because the language needs to be written in some form and, you know, we'll just do a straw poll. We won't do a formal poll on this one, vote after the floor. So do plan on being back here after the floor,
that's the point.
no matter how late, even if, unless we get everything done in the morning, which I doubt.
Okay.
You never know.
What is the drop dead date to have?
Tomorrow.
Tomorrow,
Tomorrow is the date, okay.
that's why I'm
All right.
asking.
Yeah. Tomorrow.
All right, all right.